oral maxillofacial surgery as a smart revision. Uh, Firstly, we will start with the incisions. That is going to be like retromandibular incision. Very, very important thing. That is like it provides access to the angle and ramus of the mandible of the and also it has an advantage of avoiding the branches of facial nerve and facial artery and vein. But the retromandibular vein poses the problems to this incision. That is like this is done at the angle of the mandible. You can see in the image, and then it also poses in a problem that is like there is a damage to the retromandibular vein if at all it is done improperly, and but at the same time it is going to have advantage by avoiding the facial nerve and facial artery. Coming to the preauricular incision, it provides the access to the TMJ. That is like, see, that is done. You can see in the image. That is like in the preauricular area, it is given, and it provides the access to the TMJ. See, the major important access for this provision of this preauricular incision is that access to the TMJ, and it is made anterior to the ear, and the upper margin is curved anteriorly in order to save the auriculotemporal nerve, and the incision should be never be extended downward beyond that is beyond the pinna to avoid the injury to the facial nerve. If at all it extends, it is going to damage the facial nerve. Coming to the algae Bramley incision, it is just modification of preauricular incision. You can see preauricular incision is just like a somewhat like only in the anterior region, whereas in the algate Bramley incision, we'll be extending it superior and in the forward direction, so thereby giving a question mark appearances. Just like question mark we have, right? The similar kind of appearance will be given. Um, and the gills temporal incision, very, very, very important thing. That is like it is done for the zygomatic fractures, and also it is inserted at an angle of 45 degrees to the zygomatic arch. So thereby we can just push the or we can lift the zygomatic arch, and thereby we can split it down. And submandibular incision, this incision should always be placed 2 centimeters below the inferior border of mandible. You can see in the image to avoid the cutting the marginal mandibular branch of the facial nerve. See, we have a facial nerve, right, which is 5 margins at the angle of the mandible. That is going to be the like downwards. It is going to be cervical, mandibular, facial, and also superior temporal nerve, right, and superior labial, superior inferior labial. So, in order to avoid this branch, that is the marginal mandibular branch, which is a terminal branch of the second terminal, sorry, it is the second terminal branch of the facial nerve. So, in order to avoid that, we have to give this submandibular incision. At the same time, we need to take care of the not to damage this nerve. It is used for the surgery of the body and angle of the mandible and submandibular salivary gland. So that's why the name has been given to submandibular incision, because through this position we are going to assess the or we're going to come to the submandibular salivary gland. So at the same time we have to take one precaution, that is marginal mandibular branch of facial nerve to be not to be damaged. And residence incision is slightly curved incision placed 2 centimeters from the lower border of the mandible. You can see in the image 2 centimeters below the lower border of the mandible, and it is used for the surgery of mandibular angle and ramus area. Coming to the brows incision, it is made in the eyebrow to give access to the frontozygomatic suture area and lid and infraorbital incision. This incision is obtained for to give access to the zygomatic maxillary suture area and floor of the orbit. Coming to the intraoral incision, see intraoral incisions also one of the very frequent, that is like Ward's incision. They are used for the elevating the mucoperiosteal flaps, and it is important to maintain the integrity of interdental papilla, and scars are not visible in the intraoral incisions. As I said in the one of the subject, that is like see, in the extraoral incisions we will be having a scar development, whereas in the intraoral incision you will not develop any scar at all. After healing period, you will see like is there any surgery has been performed, like that it will be, because for the implants or for the full mouth implants that we do the incisions, right? So when the healing has been completed, when we suture it back, and after healing has been completed, we feel like it is completely as natural as it is usually present. Coming to the Watts incision, this is a L-shaped incision for raising the L-shaped soft tissue flap for the removal of impacted third molars. Horizontal incisions. These are internal bevel incision, clavicular incision, interdental incision, and they do not have the vertical releasing incision. Vertical incisions are made along the line of the along the line angles of the teeth for elevating the triangular flap. See, simple thing that you have to remember is the vertical incision is suppose we have to elevate the flap. We are given a clavicular incision. Then we have to give the incisions like this. So that one basic fundamental is that base should be of the flap should be broader than the apex. Okay, that should be followed, and it is given these incisions are called as vertical incisions. Simple thing to remember. And these incisions are given with the help of these BP blades, that is like number 10, blade commonly used for the skin incisions. Whereas number 11, 12, and 15 are going to be used for the intraoral surgery. And these can be direct image based questions. Number 11 is utilized. You can see this is a number 11 where it is utilized primarily for making the small stab incisions such as for the incision and abscess drainage. If at all we do encounter any kind of abscess, then or any kind of swellings or incision, then we can use this incision. That is like with this BP blade. And number 11 and number 12, the blades are commonly used in the gingivectomy. These are very commonly used in the gingivectomy. That is like 11 and 12. You can see 12 one, it is going to be like this. And number 12, the hook blade, commonly used for the mucogingival procedures, and the blade used for incising the periodontal abscess. And you can see this is the number 15 BP blade. It is most commonly used in the for the intraoral surgery. See, whenever we elevate a flap in order to give a clavicular incisions or any kind of like vertical releasing incisions, all the incisions are done with this blade only. That is like number 15th one, which is utilized. Uh, and coming to the like this two one, this second that is a number 10 BP plate is also very frequently used, and it is most commonly used in the prosthodontic work. That is like for the our that is like impression compound trimming, and also for the secondary impression making procedures. Green stick compound, you have to trim it off. We will be using that. And bone is usually removed with a monobevel chisel. That is like, see, monobevel chisel means which has a bevel on only one side, like this. And teeth are okay, are usually sectioned with a bibevel. That is like, bibevel is going to be bevels that are present on two sides. Then it is called as bibevel, which are used done within a used to section the teeth. And the technique that most surgeons use while removing the bone is the burr and handpiece. That is like, see, whenever we extract in a third molar, that is impacted molar, we will drill the tooth with the help of burr, not at all with the sitting and hammering, right? Hammering is done for the bone procedures. And the handpiece must not exhaust the air into operative field because the air exhausted into the wound may be forced into deeper tissue, resulting into the emphysema. And this problem is more with the high-speed eroters and used for the routine. That is like, see, erotor is not at all used for sectioning of the crowns for the impacted molars, whereas we will be using our micromotors, that is surgical and pieces are present, which will exert in a very less force and also very less RPM is present for it, so that we will be cutting the crowns into two parts. That is like, um, suppose this is in a third molar, suppose, then we will be cutting it into anterior and posterior parts. So thereby we can remove it off. Later by if we can remove it off in the third molars extraction I'm speaking about. Okay, simple things to remember, right? And coming to the dental elevators that are used to luxate the teeth by expanding the alveolar bone and to remove the broken or surgically sectioned roots from their sockets. And extraction of the distal most teeth in the arch is going to be done with it. And you can see the principle that is like wheel and axle is going to, this is one of the very, 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 very important thing that is like wheel and axle is principle going to exert about 4.6 the force that is normally applied. And wedge principle is going to be applied 2.5 amounts of pressure. And lever principle is going to be that is triple I, that is 3 times the more. And winter elevators, this is the type of crossbar elevator with a triangular blade, and it works on a wheel and axle and wedge principle. And Apex elevators resembles the elevators but have a biangular. That is like it is a, they are somewhat like this. So thereby we will be elevating the teeth, and also like the London hospital elevators where the cryos, see they are used to replace the cryo elevators, but the blade is straight rather than triangular and has a convex and flat surface area. This is one of the very, very important thing that is like for the elevators, that is like wheel and axle. That is going to be like a wheel and the axle. This going to be 4.6 about of pressure is going to exerted. And most commonly we will be combining all these principles together whenever we are extracting any kind of teeth or root stems. Because at the same time, when we are elevating, when we are inserting it, we will be rotating it roundward, right? So thereby wheel and axle force is going to be exerted. Thereafter, the wedge principle is going to also be impacted because we are creating a place in the socket. And also lever principle, that is like it is going to be first order, second order, third order going to be. You can see the lever principle, that is like fulcrum and short arm, that is like a resistance is going to be exerted by our teeth, and effort is going to be by our hand. And fulcrum is the junction of the elevator with the bone. So thereby we can pull out the teeth. Coming to the triangular or pennant shape, these are cryo elevators or crossbar elevators, usually available in pairs and most often used when two broken roots remain in the tooth socket and adjacent socket is empty, and it is going to be pick type, and the crane pick or root pit on the apex elevators used to elevate the broken root from a tooth socket. It is usually necessary to drill a hole into the root, and tip of the pick is inserted into the hole. The root, these are the recent advances I can say, because like we can just drill, and then we can insert this elevators. So thereby the tooth will be engaged into this elevator. So thereby we can just pull it out. That's why it is called a pick type, polypick type, right? Similarly, it is going to pick up like that. Coming to the biopsies, that is an excisional biopsy and incisional biopsy. Excisional biopsy is done in very small lesions of diameter less than 2 centimeters, whereas incisional biopsy is done by removing a wedge-shaped segment of the pathological tissue along with the surrounding normal tissue. And see, the significance of this subject has to be remembered, because if at all we encounter any kind of tumors and cyst or any kind of like lesions, then definitely we need to do the biopsy, because we have to determine it is a pre-malignant lesion or condition, or this condition is going to, or the tumor is a that's like a benign tumor or malignant tumor, has to be diagnosed, right? So that is why we have to know, and definitely one biopsy related question will be definitely asked, because like with the shift in the lifestyles, much more commonly these tumors and malignancy are being increasing. So that's why definitely this question is going to be one of the very, very important thing. An aspirational biopsy is useful in the deep inaccessible sites like in the metastasis. An aspiration of suspected cyst-like lesions is often diagnostic, and punch biopsy is used in the mass screening of cancer patients and utilizes a special instrument for the removal of the small segment of the tissue. Coming to the exfoliative cytology, refers to the removal of surface cells of the cytological examination, and they are used for both diagnosis and routine screening of the patients with oral lesions and recurrent carcinoma. The stain used to in exfoliative cytology used for screening of carcinoma is papillary colon stain, is what we use for this exfoliative cytology. FNSE is indicated in localized palpable mass like salivary gland, neoplasia, or lymph node. And the needles that are used are 23 to 26 gauge and it takes very little time and causes a minimal discomfort to the patient. Okay, the FNSC is one of the very very important thing. Very frequently that we will be performing, especially in the our salivary gland, also for our lumbar region for the spinal cord. Also, we will be using this FNSC needles. Um, Coming to the needles, that is like straight needles, which are going to be see needles are classified into two types. That is straight and curved needles. Straight needles are not at all used in a dentistry at all. Curved needles are going to be 3/4, 3/8 of the circle or 1/4 circle. You can see in the images, right? And shape in cross section is also going to be that is like so. Suppose I am cutting it. I am cutting it. Then it is either it is going to be round or a bevel one or reverse bevel is going to be present, and flat needles are present, and traumatic needles are those needles with eye, that is like the eye is nothing but just like this one is called as eye, and without this is going to be non-traumatic needles or atraumatic needles, and thickness of the needles are going to be 10, 20, 30 and up to 11 is going to present, and size of the suture is usually designed by the series of the zeros. That is, the larger the suture will be, that is like 20, 30, smaller the sizes would be. While 40, 50 sutures are going to be wide one. That is like, see, a larger suture will be like these are going to be a wider one, and these are going to be a smaller one. Simple enough to remember. Because more the zeros are going to present, so thereby it is going to be much more finer or much more smaller in size. It is going to be. It is like vice versa thing. So you can remember like it's inversely related. Coming to the sutures, which can be of resolvable or non-resolvable. Resolvable is going to be catgut, chromic catgut, polyglycolic, and polyglactate. Whereas non-resolvable is going to be silk, most common intraoral suture, nylon, that is a popular skin suture. It has a shape memory, just like a stainless steel, and Vitalium, Dacron, and polyester coated Teflon are also can be used as a non-absorbable suture. And suture materials are used to hold the several that is severe the tissues in close approximation. That is like whenever we place an implant, suppose as I am as a prosthodontist, I will be placing an implant, right? So thereby, what I will do an open surgery. That is like I will cut the, I will first give an incision followed by an, then I will do go ahead with an osteotomy drills. So after the drilling has been done and implant has been placed, so I need to approximate both of the tissues together, and that is done with the help of suture materials. And more the zeros in the number, smaller the diameter of the strand is going to be. That is 50 and 60 are going to be for the skin's closure, and 30 is for the mucosal closure. It can be a very important thing. That is like 30 can be utilized for the like that. They can ask you direct questions. Coming to the packing of the wounds permits a healing by intention. That is like primary intention and commonly used for packs for the iodoform gauze in the soaked in the antibiotic paste, betafine or petrolatum. Most commonly, we will be using a betadine. A normal dressing should be changed after 24 to 48 hours, and when training is used, the dressing should be changed every 24 hours. That is like if at all there is any some abscess or any kind of like a cyst or tumors, then they have to be drained every 24 hours, and drains are used to provide exit for the pus and infection and to outside, and also to prevent the formation of hematoma or seromas within the soft or hard tissues. Types of drains going to be glow drains or rubber drains are the two types of drains. And in periodontal surgery, 3 by B, reverse cutting wedge needles, and 30 black beaded silk is used, and absorbable sutures are used for the grafting. See, very frequently, like whenever we place in a graft, that is like, suppose we have been increasing the ridge augmentation procedures, then we have to place a graft, right? So thereby, over this graft, that is like I will explain you. Suppose a very good example is going to be immediate implant. I am placed an implant, then I placed a graft over this area. Okay, and then this graft area should not be contaminated from any kind of extra oral materials. So thereby, I will place any membrane over it. So then I will suture it up to the flap. So thereby, and these sutures are going to be resolved by itself. It is one of very frequently used for the grafting procedures. And presence of sutures increase susceptibility to infection by a factor of 10,000 times. That is like whenever we suture it up, chances for the infection is very, 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 very less. Coming to the flap, that is like basic requirements of flap is going to be designed to provide an adequate exposure of surgical area. See, never ever hesitate whenever you are elevating a flap. And flap must have a broad base and good vascular supply. This is a very, very important thing and very frequently asked thing. When placed back, the flap should rest on the healthy bone. Okay. See, the thickness of the flap is also should be adequate. Otherwise, it undergoes necrosis. And the base should be broader. See, broader in the sense means it should be like a somewhat like this. It should not be like an see. This is the tip and this is the base. It should not be like a square, or it should not be like a like this also. If at all it is like this or like this, it is undergoing a necrosis. Main complications of the flap surgery is going to be flap tearing, flap necrosis, and flap dehiscence. And types of flap are going to be full thickness flap, that is based on the mucoperiosteal, and the partial thickness flap. And based on the shape of the flap, it is going to be annular flap, two-sided triangular flap, three-sided rhomboid flap, or semilunar flap is going to be present. And type C, it is going to be labial or buccal flaps, palatal or lingual flaps. Coming to the annular flap, the incision along the pregingival margin with no vertical incision is given. Whereas two-sided triangular flap is the one, it is an annular flap with a dressing. You can see in the images, right? See, simple clavicular, if at all we give just a clavicular incisions, then it's going to be an annular flap. Whereas a two-sided triangular flap is a flap with a releasing incision only one side. Okay, on only one side. A very good example is going to be our this Lidman's flap. Okay, and then three-sided rhomboid flap. It is a modification of two-sided flap with addition of second vertical incision. You can see this is a second vertical incision that is given to elevate the flap. And semilunar flap is designed when periapical area is required to be exposed very frequently in the retrognathic fillings. That is like for the endodontist people, if at all they have to go ahead with a retrognathic filling. So then we can utilize this type of flap. And it is also kept away, that is 5 mm away from the gingival margin. And also suppose if at all there is an infection in the only in the apical region. So thereby we can just create a semilunar flap, and then we can just remove the bone and relieve the infection with the drainage procedures. Coming with the pedicle flap, it is a flap that is based on a particular blood vessel. Example is a palatal flap along the length of the greater palatine artery. And these flaps are utilized for the periodontal surgery for the recession surgeries. That is like if at all the patient has a severe recession in the anterior region, then we have to utilize this pedicle flap, and then after it is going to give a very good results. Random flaps are the flaps that are net based on the specific blood vessels. Coming to the classification of middle third fractures, see, it is one of the very, very important thing that is like dental alveolar fractures, zygomatic complex fractures, nasal complex fractures, Leaford 1, Leaford 2, Leaford 3. See, Leaford 1 is also called as Guerin fracture, horizontal or telescopic fracture, also called as floating maxilla, because maxilla will be relieved from the base of the cranium. And Leaford 2 is a pyramidal or infrazygomatic fractures. Leaford 3 is a eye level or suprazygomatic fracture. And extended Leaford or cranio-orbitomaxillary fracture also can be seen. Leaford 1 mainly occurs or involves the tooth-bearing portion of the maxilla. And Leaford 2 involves maxilla, nasal, and lacrimal bones. And Leaford 3 only maxilla, that is like it involves almost all bones. That is maxilla, lacrimal, nasal, and ethmoidal bones. Maxillary incisor region is a common site of dental fractures and cracked pot sound on the percussion is seen in the alveolar fractures. See, much more frequently whenever the patient is like for the sports or any kind of activities, the maxillary incisor are the one which is going that is like which are going to be undergo fracture of the it. Coming to the Leaford 1, 2, 3 and fractures, you can see in the images why it is called as floating maxilla because the maxilla is being separated. Whereas Leaford 2 is going to infrazygomatic. That is like because it is going to have a pyramidal shape. So that's why it is called pyramidal fracture. Whereas Leaford 3 is a suprazygomatic fractures, high level fractures, you can see completely zygomatic bone has been separated from it. Actually, the name Leafords have been given by a scientist called as Leaford. What it did is like it took under skulls and it just thrown them on the ground. Then he has observed that most commonly three fractures were only observed in all these under skulls. That is Leaford 1, Leaford 2, and Leaford 3. That's how that the names have been given, which is given in this Manipal book that is like a general surgery. And fractures at the angle of mandible are influenced by pull of the medial pterygoid, masseter, temporalis muscle, which tends to displace the ramus in an upward and medial direction. See, this is one of the very important thing. Coming to the horizontal favorable fracture, when viewed from the side, the fracture line runs from the lower border of the mandible, extending upward and backward to meet the upper border. You can see in the images that is like horizontally favorable one. That is like it runs in the horizontally upward and backward directions. Whereas unfavorable one is going to be in the forward direction, downward and forward direction. You can see this kind of thing, upward and forward direction. Backward is one that is going to have a very good healing because it the muscle pull is going to bring these fragmented segments each together. Okay, if the horizontal direction of the fracture line favors the unopposite action of the masseter and medial pterygoid muscle in an upward direction, the posterior fragment will be displaced upwards. Horizontally unfavorable fracture. Here the fracture line extends from the lower border in an upward and forward direction to meet the upper border. You can see uh, it is running in the forward direction, so thereby it is not going to be get approximated by the masseter and medial pterygoid muscle pull. So thereby it is going to have a poor prognosis. And vertically favorable fracture is the one you can see. This is the view that is we see in the transverse view. I say when viewed from the above or occlusal surface or transverse view, if at all the fracture line runs from the buccal plate obliquely, that is like back and to the lingual plate, you can see it is like running like oblique in the upward direction, that is like in backward direction. But then it is going to be a favorable one. Whereas if it is going to be in the forward direction, then definitely it is going to be an unfavorable one. Because the pull of the muscles will be, it will be pulled together. So thereby the bones will be attached to each other. Whereas in the unfavorable one, what happens is this is pulled upright and this is pulled upright. So thereby the prognosis is going to be very poor. Coming to the displacement of the fracture segments, they are fractures. That is like a bilateral fracture of the mandible in the canine region. The direction of displacement is going to be backwards. That is, anterior segment is displaced backwards. And muscles that are involved are genioid, genioglossus, anterior belly of digastric muscle. And these fracture remove the attachment of the tongue to the mandible and allow the tongue to fall back and obstruct the oropharynx. Bilateral fracture of the mandible in the molar region, the anterior segment is displaced backwards and downwards, and muscle is involved are digastric and mylohyoid. Subcondylar fractures are the condyle is displaced anteromedially, and the muscle that is involved is going to be lateral pterygoid because it is the only muscle that is going to attach to the condylar segment. And the this fracture line in the midline of the mandible is going to be displacement by minimal displacement occurs, and there is no muscle that is involved in it. And the fracture of the vertical unfavorable fracture of the angle of the mandible is going to be posterior fragment is pulled lingually And the muscle that is involved is medial pterygoid. An horizontally unfavorable fracture of the angle of the mandible. We have seen right masseter and medial pterygoid which will be pulling the fragment upwards, and fracture of the coronoid process. The fragment is displaced upwards towards the infratemporal fossa. That is, muscle involved is going to be temporalis muscle, because the temporalis muscle is going to insert onto the coronoid process. See, this is the significance why we study these muscles of mastication in the anatomy, because these are the muscles that we are going to deal in the oral surgery or in, also for the prosthodontics also. Okay, see, in each and every subject it has clinical implications. Otherwise, they would not be adding in the dental curriculum at all. And the fracture lateral to the midline, the incisor area of the mandible, is going to be the direction of the displacement is going to be in the genial tubercles displaced lingually. And the muscles that are involved are genioid and mylohyoid. Because in that region, these muscles are going to be attached, right? And the important signs and symptoms of the different fractures are zygomatic and lithothree fractures will be having a wounding of the globe of the eye. The level of the globe of the eye is normally maintained by suspensory ligament of Lockwood. And if they are damaged, then it is going to result in damage to these structures, thereby giving a wounding of the globe of the eye. And zygomatic complex fracture, it is going to have signs and symptoms of retrobulbar hemorrhage. That is hemorrhage within the muscle cone. And anesthesia of the cheek is going to occur due to the involvement of zygomaticofacial nerve. See, zygomaticofacial and zygomaticotemporal nerves are going to be anesthetized while we place the zygomatic implants also, right? So similarly, these are the nerves that are going to exit out from the zygomatic facial foramen, right? Or zygomatic foramen. So thereby, if at all any damage occurs, thereby these nerves are going to be get affected. So thereby there is a paresthesia. And I guess we have less than 1 minute, and thereafter you can rejoin again. Thereafter we will be discussing. I guess very few slides are present. That is like about 16 slides were present, much more. Okay, we'll be covering even the numericals of the local anesthesia also. You can just exit and rejoin again.